Good afternoon. This is Erin with the Department of Medicaid. It's not quite 1 o'clock and we are still clearing out the waiting room. So we'll give it just a second before we get started.
All right, thank you.
And Russ, currently you're the only TAC member I see. If I missed someone while they were logging in, please let me know.
This is Lori Ritchie Baldwin. I'm here.
Hello, Lori.
Hello.
How's it going? There's Lane. That gets me my quorum.
The waiting room is almost cleared.
Okay, I'll wait till you give me the go ahead.
It looks like the waiting room is cleared. So if all the TAC members would like to turn on their camera so we can see if we have a quorum. I believe I saw one other member trickling in. I can't find them on the list currently.
We've got Elaine. I know we got me, Elaine, and Lori. So that would be 3 out of the 5.
Lori, are you a new TAC member? I don't have you on my list.
Yeah, Lori was appointed a couple meetings ago.
Can you tell me who she replaced? My apologies, I didn't get an email on that.
Teresa Fike, I believe.
Who did you say, Russ?
Oh, you may have replaced Steve Oglesby.
I think that's who I replaced.
Okay, thank you. I will get my list updated. Welcome, Lori. I do apologize.
Oh, no
so
worries.
we've got several new ones, Erin. Michelle Lawless is on the TAC.
I do have Michelle.
You have Chris McClure?
Yes, I didn't have Lori. I think she's the only one I didn't have. So I apologize. I will update my information and the website.
Okay. Great.
And the waiting room is cleared, Russ. If you would like to go ahead, I'll hand it over to you.
Thank you so much. So we have a quorum. Welcome. I'm Russ Rinaldo, the CFO at Owensboro Health, and the chair of the TAC. Lori and Elaine, you want to introduce yourselves?
Sure. I am Lori Ritchie Baldwin, and I'm the CFO for St. Elizabeth Healthcare.
And I'm Elaine Yantz. I'm the Chief of Payer Administration at the University of Kentucky Healthcare.
Okay. We don't have Chris or Michelle, do we? Okay. Need approval of the minutes of the previous meeting. They were sent out. Any TAC members have any changes or edits?
I don't. I'll make a motion.
Okay.
And I'll second it.
All right. All those in favor?
Aye.
Aye. Okay. Old business, sepsis work group update. I think I could probably give this. We have a subgroup to talk about the sepsis movement from sepsis 2 to sepsis 3 that occurs next January of 25. We met in January with the cabinet to discuss, and we discussed multiple items and questions, and the cabinet was going to come back and answer some of those questions and give us some additional information. Our February meeting was canceled due to some conflicts, so I believe we've got one on the calendar for March. So we'll continue that on and report out that to the group. Anybody from the cabinet on the HRIP, the 2022 quality overview or review results?
Yes, I am. Good afternoon. I am Angie Parker. I'm the Director of Quality and Population Health, and I have a few little slides to go over the Hospital Rate Improvement Program, also known as HRIP.
Thank you.
You're going to have to excuse me. Hoping you're seeing is the presentation. Okay. So I am going to address the quality aspect of the Hospital Rate Improvement Program.
Angie, do you have a presentation up? Because I'm seeing your Excel.
Yes, I
Double
do have a
checking.
presentation up.
Just double checking.
Well, let me stop sharing that and I'll get back with you.
There was a presentation up initially, but then it flipped to the Excel.
Well, that's the HRIP measures for 2025, actually.
Yep.
That you saw in Excel. Okay, now can you see the presentation?
Yes.
Very good. Okay, so the Hospital Rate Improvement Program that most of you should be or are familiar with started in, I think, 2019, and then it got changed in 2021. And we have been working on this what it's basically a directed payment program that allows Medicaid to provide enhanced payments to providers, and it's based on quality and based on the utilization and delivery of services and it's to advance at least one goal of Medicaid's quality strategy. It's evaluated at the end of each program year. Unfortunately, we have to do this every year. We have to submit it to CMS for approval annually. And this HRIP is funded through a hospital assessment, and it's per this specific statute. The HRIP program is designed to achieve two main objectives, and that's one, to improve quality outcomes and to maintain access to services. For whatever reason, that's not it. Okay. Can you still see where it says 2022 HRIP program?
Yep.
Yes.
All right. So we, as I said earlier, we Medicaid in the quality department and our finance department, we work with Kentucky Hospital Association on determining what quality indicators or what quality measures we need to focus on each year in order to improve the quality of care. In 2022, 84% of the hospitals achieved at least 4 of the 5 hospital-specific goals. And in 2022, 50% of the hospitals achieved all 5 hospital-specific goals. So what are those measures and goals? So here are the data metrics for calendar 2022. And if you'll notice, there's a lot of asterisks by the top 4 of these, and that's because that it provides who is included or excluded in these particular metrics. So CAUTI being the catheter-assisted urinary tract infection, that's what everybody is in the hospital knows it is CAUTI. And then you have C. difficile, which is a gastro issue. It can be obtained either via contact from person to person or for overuse of antibiotics. hospital readmissions, and that's a 30-day all-cause sepsis screening and triage and bundle compliance. So the psychiatric specific measures, we have those listed there, and the safe use of opioids, which for 2022 to determine provider education. A rehab specific measure, which is discharge to community, and social determinants of health. This is a list of all those quality measures that we just saw and what the benchmark was for 2022 and what each individual hospital goal. As you can see with a lot of these measures that in 2022, we were establishing benchmarks. And there were some activities that were to be done in that time period in order to help establish a benchmark. And for the results, as you can see, the 30-day readmission goals for A and B, and could do a little bit better in that area. Also, this CAUTI standard infection ratio and the CAUTI low volume rehab or LTAC facilities need to improve on those areas significantly. Also, for continued on with these, the C. diff standard infection rate ratio could use some work, as well as the for rehab or LTAC, and the others that are benchmark years for metrics are looking pretty good as far as those that are applicable for those facilities that are applicable. So that's it, really high level regarding the ATRIP and the quality aspects of the program for 2022. I just wanted to show you this page, in which is on the Medicaid website, that shows where the Medicaid managed care quality strategy and where it is located, and how the ATRIP also is to connect with the Medicaid managed care quality strategy. And we also have other quality reports. We don't have a specific ATRIP on there now, but that may be something we will be looking at in the near future.
Can you send that? Can you have Erin send that link to Erin so she can send it out to us?
I'm sorry, Russ, I can't hear you.
Can you have Erin send that link to Erin so she can send it out to the TAC?
Absolutely.
That'd be great. And then
And
was
she'll
there
be giving you this presentation as well.
presentation? Oh, that's awesome. That's great. Was there anybody did we have any hospitals that didn't chase the goals at all? You know,
It did not.
they got zero goals, like either didn't report or didn't make an effort.
Well, I'd have to go back and look. I don't, to see whether or not that was addressed in the report that I have. I might have something on that. And if you want to go on to the, if there's any other questions that I may or may not be able to answer, I can go look on a report and come back to that after you go through the agenda.
Okay.
Yeah,
that's
I
fine.
have a question.
Go
Sure.
ahead.
Well, I have a question sort of related to Russ's question. If there are hospitals that got zero or maybe got one, so it looks like maybe they weren't chasing some of that, I guess the question is, what can we do as a hospital association to follow up with those groups in order to help them improve to get more than that?
Yeah.
Well, I do know that
think
KHA works with each of the hospitals that provide the data in order to help identify where there are issues and help with education and a lot of different things that they are there for the hospitals to help in their quality initiatives.
Thank you.
So is the hospital association aware of each individual hospital's results?
Yes.
Okay.
They KHA obtains all the data.
Okay.
And we have a vendor in which we work with, Myers and Stauffer, who helps put all of that into an Excel spreadsheet and how all of that, who's meeting and who determines the amount they get, amount of money they get. And it is looked at, as I said, we look at this at least annually, and to see whether or not there are any changes that need to be made for the upcoming year. And we are already working on 2025.
So Lori, maybe that's a question we have for Deb Campbell, right?
Yeah. Yeah.
Ask her that. I mean, and to the point is, the withhold is now, 10% on both inpatient and outpatient. This 22 was, I think, a 5% on just the inpatient, right? So it's a lot. It's grown.
Yeah.
The amount of dollars has grown a lot.
Any other questions?
No, Angie, good seeing you. Thank you so much for presenting.
Not a problem. And I'll see if I'll look back to see if I can find out whether or not no hospitals met. And I'll let you know if I'm able to find out during this meeting. If not, I'll let Aaron pass that information on.
Okay. All right, moving on to new business. I'll look to I think Michelle Lawless is here, Aaron, as well. I saw her join the call. One of the new business, some of the TAC members to help with some of these issues or questions or issues have come up through the membership. The NDC issue, there's multiple, and I realize that as we go through these, there may be bringbacks after we've gone through what some of the questions or concerns are. They're on the NDCs. I think we have multiple hospitals reporting that they are getting denials for compound drugs for no NDC, where there is no NDC number, from multiple MCOs. That they've tried to resolve and cannot get any traction on. So that's the first item in their NDCs. I think the second item is that there's concerns that there's no uniform source of truth on NDCs. Apparently there are, as I understand it, there are multiple NDC tables. And DMS has shared the DMS source of truth, but did not mandate that the MCOs use the same source of truth. And we are seeing hospitals report a good volume of denials because the MCOs are using a different list or compendium of NDCs for their particular plan than has been published with from DMS. And so the concern is that if there's not one source of truth, and NDCs are based on vendors, on package size, on dosages, a lot of different things, that it's the administrative burden of multiple, maintaining multiple NDCs and having actually to purchase from multiple vendors or different to be able to get paid for drugs from the MCOs. There are concerns there. So I think the question is, should there be a source of truth or one NDC list to be used? And then you have a variation in how some of these things are being administered by the MCOs. So you've got Revenue Code 250, which is a drug revenue code, but not a specific drug revenue code, and those are being treated differently by the MCOs. So you're getting denials from some and not and others. Anybody else from the TAC miss anything that you know of and or heard of in the hospital costs.
I don't have anything else to add. I think you covered that.
I agree.
And I don't know if we have anybody from the cabinet can talk about it, or we need to table it to bring back to the next TAC in April.
Russ, that may be something we need to bring in our pharmacy group on. I'm not positive, but I will put that on the follow-up in case there's no
Yeah.
one that can speak on it today.
Yeah, that would be wonderful. So I probably figured, but that would be wonderful if we could invite the pharmacy folks to the next meeting, see if someone from that group can attend.
Yeah, this is Steve Bechtel, Chief Financial Officer in Medicaid, and Russ, it may be good if we have a couple examples so that we can do the research on our end as well.
100%. I understand, Steve. We can get you those. Okay. Thank you. Go to the next one. SB 20 issues. I think they're these are the appeals. I know there's a backlog that still exists, and I know we're trying to get through those. I know the cabinet's doing the best that they can. I think I'd like to see if we can get an aging inventory of the SB 20 appeals, and see if we can get that for the next meeting to kind of see how many cases and how old they are, so that we can discuss potentially what the plan is to clear the backlog. Anybody else from the TAC? Anything additional on that? I think
No.
that's my ask, if we can get an aging inventory report, number of cases, how old they are by aging category. Anyone on the cabinet side want to chime in?
Well, I'm trying to understand where this is, Aaron. Do we know who?
Steve, I believe that would be under Edith's group. I believe she is the director over, and Stephanie Hodges is the branch manager. So I have it on my follow-up list. I don't
Okay.
see Stephanie.
I'm on here. I was looking
Oh,
to see if
thanks, Edith.
Stephanie. I was looking to see if Stephanie was on the call. I'm sure we can pull some kind of report. I've made a note for her to have it ready for the next meeting.
Okay. Thank you. Next item is retro authorizations. We're still getting numerous reports on inconsistent treatment from the MCOs, across the MCOs, on retro authorization. We're seeing denials for lack of authorizations on retro assigned members, which isn't possible to achieve. And we're seeing MCOs uphold the appeals for those denials. And we've got questions from the member hospitals on path to obtain payment for those. Specifically, I've heard it in the behavioral health, inpatient claims being denied for lack of prior authorization. I don't know if that's due to behavioral health being a different group than the medical side on some of the MCOs or not.
Is there anyone from any of the MCOs that would like to speak on that?
Yes, this is Melissa Carson from Humana Healthy Horizons. We are aware of some of the concerns that the hospitals have brought forward, and they've been escalated, and our policy is currently being reviewed by our senior leaders, and we'll provide an update once we have some additional information to share.
We'll be able to have that at the next meeting, Melissa.
Yes, yes, we should. We should be able to provide information then.
Okay.
Thank you.
From the TAC members, are there others that you want to talk about there?
I don't have any.
Okay. All right.
Are these are you just seeing this in the managed care arena and not the fee for service, or is these retro enrollment people that are, they have 90 days to come back on and it's retro back to the date that they drop off? Russ, what are we talking about here? Just
To my knowledge, so they're retro, yeah, they're retro assigned members. It's somebody that gets a date that's retro assigned. They come into the hospital and they don't have Medicaid, and then they get retro assigned back to the day that they came into the hospital, and then we're being asked for an authorization and then getting denied for an authorization. I don't believe it's the indemnity side. I believe it's all MCO side.
okay.
And I'll make sure that we've got, if there are other MCOs, we'll have examples, but we'll also ask them to bring the policies to the next meeting as well.
Yeah, it's always easier for us to do our research on our end if we have specific examples to kind of look into. So.
Yep.
And I have a
Russ,
question on.
oh, go ahead, Lori.
go
I'm
ahead.
sorry.
Go ahead.
I was just going to mention I can send you guys the MCO dispute form. That department put together a very nice laid out form that might make putting some of your examples a little easier together. They've got a nice Excel sheet and everything. So I will email that to the TAC again after this meeting.
Thank you.
My question isn't on retro authorizations, but it's more around free auths related to this whole Change Healthcare issue. So maybe we can get through these and talk about that as other items.
Sure. We sure can. Okay, I've written it down. Next item, MCO vendor requests. I think this is an issue that for MCOs that specifically use Optum. I think as I understand it, the hospitals have to go through PaySpan, and then they call Optum. They don't have a place to send the medical records, and then they receive a denial, but they can't act on it immediately because they have to wait for Optum, in some cases 2+ weeks, to send a barcode which identifies where records need to be sent. So it sounds like it's a pretty awful process from what we've been reporting on. They reach out, when these hospitals have reached out to the MCOs have just told them to go work with the vendor. And so I guess the question is, at what point, with a frustration with a vendor that you can't get an issue worked out, that we have to address it, and what can we do from the TAC to address it?
Hey, this is Greg from UHC. This is the first that I'm hearing about this particular issue. So it may just been outside of my radar. I would love to get more information about what this process looks like, if possible.
Okay.
I'd like to pass that along to some of my counterparts in the Optum organization. So I can put my email address in the chat. And if I could get just some quick bullets around, here's what the process looks like today, here's the roadblocks that we experience, that would be really helpful to me.
And I don't know that it's with UHC in particular, surprisingly enough. I understand it's WellCare.
Yeah.
Okay.
And I was going to say, yeah, sorry, Russ, this is Stuart Owen with WellCare. This is the first time hearing it too. I know we use Optum. I'll put my email in the chat. Just kind of echo what Greg said. If you could put a description, and we'll outreach Optum, because I was not aware of this, but I'll put my email in.
Okay. we can absolutely do that.
And Stuart, I'll tell you, you and I collaborate on different initiatives. If there's anything that I can do to help you to connect to the right people, let me know.
Thank you, Greg. Appreciate it.
For sure.
And as I understand, I mean, the process as they've described it to me just seems backward. And so I think it's just getting through it and seeing what we can do.
Hey, Russ, this is Christine Pursuta from St. Elizabeth. I'm new to this format. I didn't know, can I add some context to that conversation for you?
100%, Christine.
Sure. Okay. Some of the issues that we're having with this is that the way that the vendor manages the request for records. So with the MCO, let's say WellCare is one that we have a high volume for, is that we will get a denial issued with a CART code requesting medical records. So that goes to our team, and then they are thinking that WellCare actually is wanting the records, and then they're doing an upload and providing that to WellCare through their portal. Then through correspondence, which could be received a couple weeks later, we would get a letter from Optum stating that records actually need to go to their vendor Optum. So then now we've had this situation where we've already released the records once to WellCare, thinking that's the initial request, but then now we actually need to go to Optum and submit it through their portal. And we can't, from the information in the CARC code, so in the denial information, we're unable to just act directly and go to Optum, because Optum's site requires that there's a barcode that we have to put in order to complete that submission. So it's a burden for the provider in the aspect that we are then being issued a denial for which we cannot act on for at least a couple weeks until we determine if it's WellCare or Optum that needs the records. So that's one issue.
Okay, thank you. I appreciate that.
The other issue that we have is whenever there is a disagreement with the outcome of an Optum review, there seems to be some discrepancy on who we're managing that with. So, the plan will say direct that to the vendor, and the vendor will redirect us back to the payer. And then the provider's stuck in the middle of that with getting resolution on their claim.
And
Christine, is that a specific MCO issue, or is that multiple MCOs with that the second item?
The two MCOs that we have the biggest issue with this particular issue is Passport and WellCare.
Does the letter, so you're getting a letter, right, with some kind of whatever decision, determination, or ruling? Does it not say send, if you want to appeal or whatever, send to wherever?
It does, but it doesn't always give the full description of what the issue is.
Oh, of the actual rationale, I guess.
That's correct. So I think the recommendation that we've made through the KHA calls is that if an MCO is working through a vendor to secure records, then why would they not just issue the CAR code, allow us to upload it through the payer's portal, and then they can be responsible for forwarding that on to their vendor versus making that the administrative burden of the provider and causing duplicate work.
Okay. Yeah, I'd appreciate anything in writing from anybody to help research, investigate on the WellCare side.
Right.
So Stuart, it is the process that Christine described, kind of drafting that up and sending that directly to you. Is that kind of what you're looking for?
Yes, please. That would be wonderful. I've got my email in the chat. That would be wonderful. Just some bullets.
And if you could copy Aaron Bickers so that we have it for the TAC at the department level, so that we know the, don't exclude us, here at the department. We'd like to be a part of that.
100%.
And is there someone from Passport on that we could also send that to?
Yes, I will. This is Nicole. I will put my information in the chat. We've been working on this issue for a while. And again, the process works as it is currently intended, but what we've attempted to do is to see what we can do to enhance it so that there's not any duplicates, and it's really clear on where you're going and who you're going to. So again, I'll drop my stuff, my name in the chat.
Any other discussion on this one? Okay, thank you, everybody. Next item, emergency department policies. So I think the MCOs, we've had multiple reports on ER down coding based on policies that the MCOs have adopted. So visit level down coding based on policies that I think DMS has approved for the MCOs. I think some of the questions that I've heard, or what I've heard is that these denials or these down codings, which are denials, are coming through remits on the MCOs. So the code is being downgraded and processed through a remit. There's not necessarily denial letters that are being generated. So when we talk about a denial, you know, from a need to appeal or desire to appeal, you have to know the rationale about why it is, right? So if it's going from a level 4 to level 3 or level 3 to level 2, there should be some clinical rationale and reasoning that comes back to the provider in a letter. And I don't, as I understand it, that's not happening. It's what I can understand, it is going through a program, an ED optimizer that is by a vendor with these MCOs, and it's generating a down code. The problem with that is that I'm not hearing any results of it generating up codes. So if it's only looking at it one way, I have a problem with that. I said that the second thing is that I know folks that have the same tool on their own side. When they submit the claim, they're getting down coded, even though they're using the same tool. So knowing how the tool is working, what the rationale is for it to down code, you can't, you know, how it's set up is important in all this, rather than just something that may be arbitrary or wrong, potentially, coming through on a remit. Anybody else from the hospital side or the TAC on what I'm saying, and I'm misspeaking or missing something?
Not for me.
So so I guess my request is from the cabinet side, you know, if it's a denial, there should be letters that are generated and it has the clinical rationale or the rationale of the denial, not to say that, you know, this level is a level 3 and it should be a level 2, or this was billed as a level 4 and it should be a level 3. It has to have a reason. And I don't think the hospitals are getting that at all. And if you're gonna, and I've had reports of having 4 figures, over 1,000 of these cases for at least one hospital.
Russ,
So
this is Tom.
Real easy to put in and program a system, some program to apply some criteria that, from my viewpoint, can be manipulated, because otherwise it would be the same when you submitted the bill versus the same on the review. What that clinical criteria is and what the rationale and reason it is.
Russ, this is Tom with Baptist, and if I may, just very, very briefly, you know, our experience is that, you know, to Russ's remark, these are automated down codes. They're not the result of a medical records review, and when they come across, from what I'm being told from our staff, there's not even the notation in really the remit that's noting any appeal rights or what you do if you're going to contest it on any kind of basis. It's just an automated blind reduction in the coding and the reimbursement.
Yeah, Russ, I would agree with Tom in those regards. And, you know, we've had several lately, so I know exactly what you're referencing.
If that could
Right.
also, sorry, this is Erin, if that could also be something you could send us some examples, we can send over to policy and also the MCOs and have them do a little research into that and bring that back to the April meeting.
We
So,
can,
and this is Steve again. I'm sorry, I wasn't sharing my camera earlier, I don't think, but I am now. Here's my concern or my question is it predominantly under one MCO or is it across the board of all MCOs?
it's more
that
than
you're-
one.
Okay. My concern on
Every one of them has a policy.
Yeah, I think
Every
that
one of them has a policy and how they're applying that policy. And again, what we're getting back, I know we're not getting back the denial letters. So, so Steve, you can't just say, because, you can't just deny it without us knowing why you're denying it. I can't appeal something
Right.
that I have no idea what the reason is.
Well, it sounded like to me it's not a denial.
Well, it is.
And well, in terms of getting a denial letter, but you may want to get some type of notification and some information as to why it got down coded and got reimbursed at a lower level. Is that what I'm hearing?
Well, yeah. So on a DRG, right? When they do when an
Mhm.
MCO does a medical record review on the DRG, and they say we don't think it's this DRG, we think it's this DRG. I get a clinical rationale, I get a reasoning behind, and the expectation is I get a reasoning behind of why they want to change a diagnosis code or they want to change the assignment of a DRG. And then I can look at that, look at my coding. I have the ability to either appeal it, accept it, make a determination of do I want to fight it or not fight it, right?
Mm-hmm.
So if I have somebody that comes in and they've got chest pain or they have some kind of procedure or they've got whatever, and we've, coded it as a level 3, and the MCO comes back and says, through a remit and an automated computer system that has nobody looking at a medical record, nobody doing any clinical rationale, no, we're going to make it a 2. But there's no reason, right? They haven't given us the reason. And again, I know folks that have this exact system, right? This OptiMedia analyzer, and then they're sending in the ED visit and they're getting denied by an OptiMedia analyzer on the other side, or getting downcoded on an analyzer on the other side that's reviewing it. So you can program the analyzer to do what you want it to do and make it as strict, or it appears to be, make it as strict or lenient as you want based on the criteria that you're putting in. So there's not a standard, right? What's the standard? What are you looking at? What's the rationale of why you're putting it at a lower code? And if you're looking at these things, you should be looking to upcode them as well, right? You should say, this was a 3, it should have been a 4. But I'm not getting one of these that say anybody's looking at it saying it was more intense than what we coded it. So I got a lot of questions behind what the criteria is in the tool, why all these things are occurring, what's the reason for all these? Because if I get one in a remit, I got nothing to how do I respond to it? You've moved it from a 4 code to a 3 code for a reason. What's the reason? So that I can dispute it, I can argue it, I can take it through appeals. And it's no different than a DRG change.
Okay.
Still paying me, they still want to pay me, they just want to pay me less for what I billed. And and we had this with the DRGs, right? When we first started doing all these DRG reviews, we were getting these things saying, nope, we're changing it. And there was no rationale. We brought it back here. The cabinet said, you got to have a rationale and a reason so that the provider has at least the ability to evaluate whether or not they want to appeal it.
Okay.
Russ, if I may, Steve, traditionally, this is Tom Butterball with Baptist, by the way. Traditionally, in those instances where a payer was going to deny, or when a payer was not going to remit or do a down code, it's been the position of the department that they had to provide an explanation with enough specificity for the provider to be able to do something about it. And these are instances where not only is there not specificity, it's automated. It just happens.
So no one's looking at a medical record if they've got some kind of algorithm or you program the machine to do it this way. If you've got this code and this diagnosis, down code it, right? There's no looking at the notes, there's no looking at the documentation.
Okay. So,
And if we're gonna, I mean, if we're gonna be transparent about what's in that system and how that system works and what codes are there, I mean, that's another thing, but nobody's been transparent about that.
so the MCOs who was on the call, do you all have anything to add to this, or maybe take this back and come back and with the parameters and why we would downcode it and everything? And I understand the issue at hand is they just want to know why. It sounds like why it's being reduced.
So if we wanna choose to appeal it, we have the ability to do that. And again, I mean, I would ask for a formal letter so that I know the time frame. I know when the letter gets done. I know that somebody's looked at it, all that kind of thing. This is a real easy thing to put an automated computer system and put whatever parameters you want in there to not pay what I think they should be paid.
Yeah, this is Greg from UHC. I'm really curious to see instances. I think without seeing some specific examples of that happening within our population, it's hard for me to tackle. But if you have them, I'd love to see them. To the best of my knowledge, when we're down coding things like the DRG payments, that is coming with a letter, there's appeal rights. And so this situation, I would think, is similar. So I would think that you have every right to appeal that and know why it's denied. So I'll make sure that that's the case on our side, but I would love to see examples if you have them.
We'll get examples for the MCOs.
Thank
Yeah.
you.
This is Stuart again with WellCare, and I'll check with staff here about that, especially with the letter not giving rationale.
I believe, Stuart, that my understanding is WellCare is doing it through the remit.
Yeah, we are. Yeah, we're using Optum.
All right. I appreciate that.
Is there any other MCOs on other than those two that can
Passport's
address?
on, but we don't have this in place right now.
Okay.
Humana's on. We do have this in place, and we would also be interested in some examples.
Yeah, Anthem is on as well, and we would love to see some examples. Thank you.
Hey, Steve, it's Joanne with Aetna Better Health of Kentucky. I'm not aware of the process, so if you have some examples, I'm happy to put my email in the chat to get those over to us.
Perfect. So Russ, I guess we'll have to take this or table this and get some examples and do some research and put it on old business next time.
Okay, got it. Then incarceration issues, I know we've talked about this before. I think the general consensus is that we know the MCOs have gotten better at this and are working with the hospitals. I think I think we're seeing it occur more and more in fee for service, not knowing whether to process to recoup a claim because of incarceration, patients released from jail. I mean, are we, who makes the eligibility updated? I know we're just having a lot more noise reported to the hospitals on, claims where, it says it's incarcerated, but we either have gotten a letter or we know that the patient has been released. From the hospital side, I know I'm not doing a great job, relaying this. Does anybody want to speak up?
Yes, that will be me. This is Christine from St. Elizabeth. I think part of the issue is, well, you are correct in the MCOs are working and collaborating with the hospitals to work through a solution for these. It seems now the issue is more with the jails directly, getting the information updated and them taking accountability for claims that they should be paying. So I think that's some of the oversight that we're asking for assistance on is who oversees the jails and their accountability in the workflow. And when they're not following what we understand to be the process, who is accountable to doing that outreach and helping us get that resolution?
And this is Michelle with Med Center. We have the same issue and exactly the way St. Elizabeth described. And interested in knowing who can help us.
This is Billy with Baptist. I would love an answer on who is responsible for observation accounts over 24 hours, especially state inmates. State inmates in a county jail. It's a state inmate in a county jail, and the observation status goes over 24 hours.
So why is the observation status, just for my own education,
Well,
trigger?
if it goes to inpatient, if it's an inpatient, then Kentucky Fee for Service picks up. If it's an outpatient, it typically goes back to the jail itself, but these are county jails with a state inmate and they're not going to pay. They said they don't get reimbursed for it. Particularly the jailer Mike in Hopkins County, he quoted some provision or something, but he never did email it to me.
Billy, this is Erin with Medicaid. Do you mind to drop that exact question in the chat? I was trying to gather it all, so I can try to get you
Absolutely.
an answer. Thank you.
Aaron, this is Leslie. I have to reach out to DOC, Department of Corrections, and see how that flow is working. If it's
Okay,
less than 24 hours.
I was going to send it to you for guidance, so thank you for that.
Yes, ma'am.
Yeah,
So that
I was
24
gonna
hours. Go ahead.
I was gonna make the comment that Medicaid, we reimburse once they become an inpatient stay. That's when Medicaid reimburses for incarcerated individuals. Now, the issue is that you're describing sounds like for your county jails. I think that's more of a discussion with Department of Corrections, maybe. But I will say we have had issues with in the past and still do today in getting that incarceration date updated in the system by Department of Corrections.
Yes, we're well aware.
Yeah.
We're working. We know those things are getting worked on, but this just seems to be an answer no one can give us.
Yeah.
And no one wants to pay, of course.
It's not that we don't want to pay. CMS won't allow us to pay.
Yes, I get.
You know?
Yeah, everybody has their rules. I get
Right,
that. Yeah.
right. So I think Leslie's right. I think we're going to have to reach out to Department of Corrections and see what's going on from their end. On Medicaid side, if you have an inpatient stay, then yes, we would reimburse at that time.
Exactly. And this particular patient that I'm having issues with, Anthem had paid. The Anthem inmate had paid, but Hopkins County sent something saying, "Oh no, you shouldn't have paid." So Anthem took their money back. Because yes, it's a very frustrating one to say the least.
Yeah, that would be a good example to send to us.
Who does Hopkins County say they should pay?
He said it's a black hole. He's made the president of the Baptist down there aware of this black hole years ago, and he would send me documentation showing where he can't because he can't get reimbursed, so that I could put it together with all the other documentation I have.
So what I'm hearing you say is outpatients, state inmates in a county jail for outpatient services, there's no payment source.
Not if they go over 24 hours now.
It's like they're interpreting an observation stay since it's greater than 24 hours as inpatient, but that's not the
Gotcha.
status of the account. It's still truly an outpatient service. But I think they're looking at it seems like they're looking at the start and end time of service versus just the overall bill type, so to speak.
So I think it's them identifying, or I guess defining staying in an ER over 24 hours as it being inpatient, which that's not the case.
Right, that seems to be the issue. And I don't know if that's defined anywhere. What is their point of reference for making that determination?
Yeah, I'm not sure. Okay.
Any other comments? Thank you, everybody. Hey, Lori, general discussion, Change Healthcare.
Yeah, so I'm sure everyone is aware of the Change Healthcare issues, and I think we have 5 questions, and we've sent out some of those questions, and we're getting some answers trickling back in. But you know, what part of the MCO's operations are impacted by the Change Healthcare? Is it pharmacy, inpatient, outpatient? We're having some challenges with pre-certs, so if that's impacted, if it is impacted and they're going to be delayed or they can't take place, will the need for a pre-cert until the issue is resolved be eliminated? How will payments be impacted? How will remits be impacted? Those are all the questions that we have. Lots of questions. I can put them in the chat, but we'd like to understand how that's going to impact us.
If you could send those to Erin, that way she can get them out
Sure.
to them, that would be great. And then I guess from the MCOs are on the phone, you know, can you share anything that you're aware of that the Change Healthcare issue has had with organizations?
This is Stuart Owen with WellCare. Of course, it's very tight messaging. We want to be uniform, and we have updated DMS in the Department of Insurance with impact. And I would not want to say anything contrary to that. So I don't know. I mean, we have shared with them. I don't want to, say anything else here. I know this is being recorded as well, so I don't want to start improv.
I guess, Steve, you know of any operational impacts that we can be aware of that's been reported to DMS?
Yeah, and we've shared that with DMS and DOI. I'm not comfortable right now saying that elsewhere.
I meant Steve Bechtel, sorry.
Yeah, I'm not aware of that though, Russ. I'm sorry. It hadn't come across my desk. I'll put it that way. I can't say that it hasn't been for sure. But it just hasn't come to my desk for me to understand or to be, aware of it.
Well, could the MCOs let DMS know who you sent that information to so that DMS can share that information with the hospitals?
Maybe I could jump in with you. I'm sorry, Angie, I didn't mean to cut you off.
That's okay, Greg. I'm just going to say we are gathering that information from all of our vendors to find out what information or challenges there are because of this. We are currently gathering that information.
Yeah, it's Nicole from Passport. It's a pretty fluid situation. We have returned some information to DMS on whether it's impacted. I'm not aware that it's impacted any of our clinical areas or any ability to get a pre-cert, but we will investigate that just to make sure. And then we will keep DMS updated with the information that for the particular areas that it may in fact be impacting.
Yeah, and this is Humana.
I can get.
Oh, sorry, Greg.
No, it's okay. If you don't mind, I will jump in because I've got to
Yes.
drop it too. So I'm getting a lot of information around the Change Healthcare situation. A lot of things coming to me. So I can speak from just for our organization, Kentucky Medicaid, I can tell you that the things that are impacted is the receipt of claims. And so a lot of our providers use Change as a clearinghouse. And so that flow has decreased. So the flow of claims into our organization for adjudication has decreased. Nothing else within our operational stack is impacted at this time. So what I will tell you is that we are continuing to have conversations with DMS. I think every MCO is going to be impacted differently because there's different functionalities that Change provides for different MCOs. I would say that it's also very dependent on which providers use Change for services. And so with Change being an entity that services a broad scale of organizations, the impacts is going to be very diverse depending on the organization that you ask. So what I think is probably the best approach on this is all the MCOs to collectively send information into DMS and for that to be consolidated there. That way the associations can be made aware through DMS.
That would be very helpful because ultimately I'm just trying to figure out what we do with these patients. Because if we can't get a pre-cert or pre-auth, and then we're not going to get paid, you know, that's the challenge that the hospitals are having to deal with. And ultimately we want to do what's right for the patient.
For
Yeah,
sure.
just to confirm, in case any of that is Passport, just like Greg has said, for Passport, it seems to be the biggest impact is inbound claims. And we have published 2 alternatives, at least in the short term, to get those claims into us, but I'm not aware that it's impacting any ability to get pre-cert. We don't have those services through Change, so.
And Humana is in the same boat as Passport. We don't do Change healthcare for the pre-certs. I will say for the department, I do know, just because of the background in dealing with CMS over the many years, CMS uses Change Healthcare for crossover claims. So you just might want to be aware that claims processed on the fee-for-service side by Medicare a lot of times are being transferred over to the MCOs via Change Healthcare.
So when I said it hadn't come across we do not directly use Change Healthcare for anything on the department side. Now our vendors, obviously managed care organizations, probably our PBM at some sort of change. Or I think if there's another UM, I think uses it some, but we do not directly use it. So I just want to make sure I clarify what I said earlier. Nothing has come across my desk that we directly use. However, our contracted parties probably do and are impacted. And it seems like it's mostly the prior authorizations that it's not like we're getting issues. I won't say Rick Washaball is our CIO, and I've talked with him about this, and he doesn't think that we've been as a breach, but it's more of a denial of items is what we're experiencing.
That's the issue.
Okay.
Yeah, this is Leon from Anthem. So Elevance Health Systems are not impacted as a result of this event. We did communicate on Sunday to all of our providers, just the reassurance of being able to submit through the Availity system. There is one very small program that we do contract through. It's a perinatal program, educational program that 174 Anthem Kentucky Medicaid members are a part of. One of the subsidiaries called Warm Health program that is part of the Change Health, but there was no interaction between that system and our system as a result. So we would just reaffirm the submission of claims through the Availity system as has always been done.
Great, thank you.
Lori, I
Humana
think if you
also
send us
uses it.
questions so that we can get those answered, and then if any hospital is having pre-cert or authorization issues that they can't get due to a system issue or systems being turned off, I think if they can report it either to the TAC or to the KHA so that we can get it addressed.
And Aaron, I sent you that email.
I've received it. Thank you.
Lori, I'll just say at UK, we were able to start sending through our authorizations through the normal courses of business yesterday. If that helps.
Great.
Through Change Healthcare, Elaine?
No, through Optum.
Through okay.
Mm-hmm.
So that was going to be my next question, Lori. Do you, and to all the other hospitals, do you all have other options of clearinghouses, or is it just the one that you have?
It depends on whether it's pharmacy, PB, or HB. Some we have backups, others we don't. The challenge with that is we've certainly reached out to backups, but so are hundreds of other healthcare systems.
Yeah.
And so implementing that quickly has not been successful yet, but we're working on it.
Yeah, we
As are
understand. We understand how quickly systematic changes and things happen. It doesn't happen overnight or a flip of a switch. It takes a while. So I can relate to that. I was just curious if y'all had something that you, in the meantime, is there a workaround? Is my concern.
Well, we
in
have
getting claims.
Yeah, I mean, we have downtime procedures like pharmacy is a big impact for us because we use Change directly. So we have downtime procedures that we're working through as well as trying to get another vendor. But some of these, pre-cert, pre-auth questions, it's not us who has the relationship with the vendor. It's us who has relationship with the MCO or another payer that has the relationship with Change. So that's why we're asking for the questions answered.
All right. We're in that same boat with you.
Yeah.
So, but yes. We'll talk more about that, I guess, on the next call, Russ. Maybe we can bring that back and see where we're at.
Okay.
Yeah. And
any other? Go ahead.
Well, I was going to say, Steve, do you mean the next TAC call, or will there be an opportunity to kind of send out a communication in the near term so we know kind of what we're dealing with?
I would think that I'm gonna have to lean on Aaron. Aaron, what's our normal process in that manner?
Typically, when we are asking follow-up questions, I try to give the MCOs about a 2-week turnaround time to give them a little information. Sometimes they'll reach out and request a little more information depending on the ask and the research involved. But I try to give them about a 2-week turnaround so we can get that back out to the TAC for review, since it's just follow-up questions.
Right.
If you need something more in depth, like data and things of that nature, we tend to give them a little more time to fulfill those requests.
So I think I would ask that if there's a pre-cert and authorization issue, that we know straight away. They should know it, right? I mean, they should understand it now. The Change issue has been out there for a few days. They should be able to report back if we have a pre-cert and the inability to get pre-certs and authorizations. And if there are, I would ask them to tell us straight away.
Yeah, I think this is a very unusual item that it would be helpful if we had information really soon to understand how to deal with that.
Okay, I think policy is at least 3 days, but I can ask them to send it back to me ASAP within that 3-day time frame. So that way I stick within our contract frame and but still get it to you as quickly as possible.
That would be fine. I mean, I just don't want to, some of the other peripheral systems and those type of things is a different issue. But I think the one that Lori brought up about the pre-authorizations or pre-certifications, I think.
And Lori and Russ, I know you guys probably did this as well, but as a common courtesy, we notified all of our payers of what the impact was to UK healthcare, and I truly expected the same from them, which we've gotten from some, but not from all.
Yeah. Same.
Yep. Okay. Thank you, Steve. Thank you, Aaron. Thank you, Lori. Any other items or discussion?
ATRIP payment went out to the MCOs today. So you should be receiving that within the next week or so.
Awesome. Thank you.
And thank you.
Yep.
Appreciate that. Yes, sir. 100%.
And if you didn't see my note in the chat, all providers received at least 1% out of the 5% available for the first year of quality.
Oh, thank you.
So they would have made, they may not have, as I said earlier, there were the percentages that were 4 out of 5 were 83%, and 5 out of 5 were 50%. Believe
Okay.
that, right?
So your answer to your question is no, there was 0 hospitals that didn't meet. Everybody at least got 1.
Good. Thank you.
Okay. Thank you.
Steve.
Thank you for that update. MAC meeting representation, no recommendations, no recommendations out of this meeting. MAC meeting representation, I'll be on the MAC meeting. Next meeting is April 23rd, 2024. Aaron, if we could get, some of those folks, like the pharmacy, I think, invited, or if you need me to do that, let me know who we need to invite. I can have my side.
I'm happy to reach out and make sure a representative is present.
Thank you. Thank you, ma'am. All right. And being nothing else, we will adjourn this meeting. Thank you, everybody. Have a great day.
Thank you.
Bye.